Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation coming to you live today from New York City in the steamy city of New York in July 1st. Today with our special guest, Dr. Robert Rosen, who is the leading neurointerventional radiologist for vascular anomalies of the extremities and internal, as well as complex hemangiomas. I believe you've treated some of those. Many of you know him from his practice at Lenox Hill Hospital and of the AVM Center. He's been with VBF for over 20 years, and he's been doing this for 25, maybe 30 years? Doing vascular anomalies more. So welcome and thank you. And we will be taking your questions. So people are popping on right now up there. Well, we can start taking your questions at any time. So the topic is vascular anomalies and vascular malformations of the extremities. I'm not seeing any questions yet. So those of you, Corinne, April, any of you that are on, please just post a note so that we know you're on. We see a thumbs up. So our conference is October 12th in Irvine, California. So make sure if you want a free consult with Dr. Rosen that you sign up at birthmark.org. We have all of our teams that will be there. I see, April, that you're on. Can you just post a note so I can see the notes start, or the comment in the comment box, so they start scrolling through? Because I'm not seeing any comments. So if you could just post a hello, April, and get us going. I'm looking on my phone as well to see if I see it. I'm not seeing anything yet. Oops. That helps to be on the right page. So I should see, there I am. So there I am with you. Oh, 5 comments. See, I'm not seeing these already. So Corinne said hello. Let me turn the volume down. So Joanna said, my daughter has got an AVM in her neck. Is she likely to have more than one? She is 5 months old and is growing quite quickly. I'm not showing up on here, and I don't know why.
Okay. At
Joanne's daughter is 5 months old, and she has one that's in her neck. She wants to know if others, will there be more?
Usually, I'm not sure what the specific diagnosis is. It was called
she's
AVM?
Yes.
Yeah,
That's what it's
if it
called.
was a true AVM, but as you've no doubt found out, there's a wide range of terminology people use, everything from AVM to hemangioma to birthmark. So if it's a true AVM, most of them are actually isolated single lesions, and otherwise healthy babies and children. So it's unlikely there would be multiple lesions, but certainly the pediatrician can go over the child and check on that.
So Nicole has a 2.5-year-old son. He has a deep parotid hemangioma, which started growing at 2 weeks of age. He's been off of propranolol since January, and now it's been growing since then. He also takes growth hormone due to congenital panhypopituitarism, which likely isn't helping things either. His question is, what are our best options for treatment at this point? So it's 47 millimeters. So he was on the propranolol, and then they took him off, but now it's rebounding.
Yeah, I'll be honest, I'm not a head and neck person, so I would actually refer you to other people in the VBF, such as Dr. Weiner or Dr. O, and they could address that. They deal with a lot of parotid lesions. It's a fairly common location, so I would go to them through the website.
So April or Corinne can post for you, Joanna, a contact for Nicole, a contact for Dr. Weiner or Dr. O. So Tara Perry says, hello, Dr. Rosen and Dr. Lynn. I'm Dr. Rosen's longtime patient, Tara Perry, here from Connecticut. He's saved my life on numerous occasions. It's always nice to hear from these people. I've had many successful planned surgeries as well as emergencies with him for complex pelvic vascular malformation. I would not be here today if it weren't for him. Thank you, Dr. Rosen, for working so hard to help so many of us out there. Thank you, Dr. Linda, for creating this beautiful network of information. So say I told you some of your other ones get there.
Nice to hear from you, Tara. Hope all's well.
So Van Nar Long Prabang says, good morning, everyone, that they're watching from Laos. So we get people from all over the world. So there is the email for myself, vbfpresident@gmail, so I can connect you with our hemangioma head and neck experts. Bobby Joe said, hello, my granddaughter is 7. She has a hemangioma and needs to know about the sun. It's on her cheek and earlobe.
Yeah, and again, it's a head and neck lesion. At the age of 7, I'd be curious as to what it's doing in terms of its overall behavior, because at that age, it should be, if it's a true hemangioma, it should be starting to shrink or involute on its own. So you might want to get further evaluation to see if that's really what it is. And obviously, excess sun on any of these lesions, or for even healthy people, excess sun isn't good.
Sunscreen, sunscreen, sunscreen.
Right.
And again, we have, you just heard from Dr. Rosen, and we have other head and neck experts, and you can also send them photos for them to look at it and ask you some questions about history, just because it is outside that normal cycle of a hemangioma. So Rachel Eddington said her daughter has a hemangioma on her face. It has reduced a lot on propranolol. We just weaned her, but the color is still there now. Will it require surgery?
I don't know what her age is, you don't say, but clearly they could stop growing and take a while to fade, and sometimes there is some residual pigment which may or may not need to be addressed depending on location and cosmetic issues. But yeah, it would largely depend on the age. I wouldn't be too concerned if it's early on in life.
Deborah has a good question. So she says, should she be concerned if our 2-year-old's hand with the port wine stain is larger than her other hand without it? She has Sturge-Weber, and a plastic hand surgeon wasn't concerned a few months ago. She uses a hand very well, and it's her dominant hand, but she said it is larger than the other hand.
Some of these are just overgrowth problems with really no focal vascular problem. Some of them are associated with vascular anomalies, and 2 might be a little young to investigate it intensively, but probably within the next couple of years will be worth getting an MRI and MRA and seeing what the vascular anatomy is there. There may be something addressable. There may be something that's just going to be an asymmetry that stays there.
And also at our conference that we have in California every year, we have complete multidisciplinary teams, and you can be seen there. So again, check that out on Birthmark.
Sturge-Weber expert.
Sturge-Weber at birthmark.org. So Renee says she's 55-year-old female with a port wine extending from her elbow into her hand. Never had any laser treatments, not really planning any at this point. I'm not sure what the question is, but maybe.
If it's not something that's very bothersome, it really is not worth starting with laser. Laser, especially once you get outside of the head and neck area, is less effective on port wine stains anyway, and it's, especially in an adult, it can be a large number of treatments for a limited return. So unless it's something that really disturbs you, I think it's a reasonable choice to leave it.
So Joanne said, we have been advised that embolization is a treatment for her AVM. That was the woman that originally wrote about the AVM. Are there other options? And with embolization, does it stop being effective after each treatment? Should we wait before she starts to have embolizations, or the sooner the better? That was on the baby with the AVM.
Yeah. It really depends on the anatomy. Some of these with fairly simple anatomy, just 1 or 2 treatments may solve the problem. If it's very complex with multiple feeders, it could require several stage procedures, especially during the growth phase of life. And sometimes when, especially female patients reach puberty or those other hormonal peaks, they can become more active. But usually each embolization is actually a permanent treatment, but if there are multiple vessels, it can require several treatments to stay ahead of it.
So Tiara has a question. So her baby, she's 35 weeks pregnant, and the baby was diagnosed with what they call a hemangioma in utero, which I thought they don't see them. So it sounds like, and she's from CHOP, and she said the baby will be born next week via C-section, and she wants to know how likely is it to grow more, but I think they need to really
scroll back slightly.
Yep. on her back. So it sounds like
management 35 weeks.
Oh, that it may be a riche as opposed to a niche.
Yeah, I think you do have to wait for the behavior and see if it starts involuting or not. Obviously, that's the difference, and there probably is certainly no way to tell in utero that I'm aware of. And it may just be a matter of following it after birth.
Yeah, that's a good point. Chris Perkins says, I have a 13-year-old with extensive venous malformation on the right leg. She was given sirolimus for 9 months and developed lymphedema on her unaffected leg that has not gone away. We stopped the sirolimus 2 months ago, and it is not gone. Have you seen this side effect before?
I have not. She is 13 years old, so, as we were just mentioning, at that age, especially in female patients, these malformations can become more active. It may or may not have to do with the sirolimus. And sirolimus in venous malformations is kind of controversial. We generally reserve it for really intractable problems where somebody has a life or limb threatening situation, because it's not really proven for lymphatic malformations. There's certainly some dramatic responses. Venous, not so much. And as you probably also know, when you stop the drug, things tend to go back to where you started. So it's a little unclear whether it's worth starting a young patient on something that's going to be an immunosuppressive drug that may be on it for years.
So Laura Ann McKevitt said, hi, listening from Ireland. Hello, Ireland. My 5-month-old daughter has 3 hemangiomas, one on her lip, her right arm, and her knee. She has just been diagnosed with a subglottic hemangioma due to raspy breathing. We are waiting to see a consult in the UK. Do you think we should start on propranolol ASAP or wait until she is symptomatic?
I think in the subglottic area, obviously, there's some concern about airway, especially if it's in the growth phase. And I would, again, I'm not a head and neck expert, but I would urge you to either see somebody sooner rather than later. And if you want to direct specific questions to either Dr. Weiner or Dr. O or Dr. Fran Bly, they could probably give you good advice on that. But something subglottic is not something to be taken lightly.
Ariana says, hi, Dr. Ariana Fuchs, F-O-U-C-H. Your patient from Alaska. I have a VM on the side of my left foot. After my 4th sclerotherapy with you, the VM has shrunk. However, first, what do you recommend for helping shooting pains? I'm currently finishing up nursing school this year and sadly do not have time or money to go back for any more procedures. What do you recommend for everyday care?
Well, for the pain, certainly stick with over-the-counter medication. You don't want to start with anything that's going to be potentially habit-forming, that you're going to have more trouble in the long run. As far as the actual treatment, if you're unable to get direct treatment somewhere there now, kind of wrapping in compression is somewhat helpful for these kinds of malformations. Other than that, just making sure you don't get any local trauma to the area, wearing the right kind of shoes, is worthwhile. But beyond that, I don't think there's anything dramatic that you're going to be able to do on your own there.
Do you ever recommend hydrotherapy, like water therapy, or not? Is it just not effective?
I think swimming as an activity, I think is very good for mobility and strength and flexibility in terms of actually improving a malformation. I'm not too impressed.
So then Rashandra wants to know about laser treatment. Oh, she's saying that laser has helped her daughter with CMTC. That's the cutis mammarata. I always wonder whether that helps or not, but she's saying it has helped.
Sometimes it gets better on its own. So
well, it's hard to know too,
so
then,
you don't
right?
know what it's responding to.
Yeah, that's a good point. Is it the laser or is it just leaving it? Hello, Batul. Another one of your patients, Batul. Renee Warsaw DeLong, should I be using a compression sleeve on my arm to prevent my forearm from increasing in size or not? Or is it really beneficial? She has slight overgrowth, 55.
Yeah, a compression sleeve is not going to help overgrowth. If there's actual edema or swelling, it can be helpful. It used to be when there were very few specific treatments for malformations that compression therapy was the only thing there was to offer. So if you read about it and you go to certain doctors, they'll still say that's the mainstay of therapy. It's certainly harmless. Some people, it makes them feel much better. Some people find them intolerable. I don't think it makes much difference in the long run, especially in an adult. And the port wine stain itself is not really going to be changed with compression. So good for swelling. Port wine stain itself is not going to be affected.
Good point. So Samantha has an interesting question. Her daughter's 8 years old and her hemangioma is on her chest. It's not ulcerated. We're now in the stage of letting it be, but she keeps getting pains inside and also burning. What do you suggest? It's on the chest.
Again, the question is whether it's a real hemangioma or some other kind of vascular malformation. I'm not sure what evaluation has been done in terms of just physical exam or MRIs, but at age 8, if it's still active and or increasing, I would suspect it may be something other than a regular hemangioma. Not something terrible, but something more along the lines of a vascular malformation. So that would be the key thing to determine.
And she can send pictures and
Of course.
any studies to you or anyone to look at. Yep. Louisa says her son has a very hemangioma on his forehead. He's had 1 round of laser and also had propranolol. Is there options to remove it because it's very large and he knocks it a lot? And again, they're from the UK, and the main center we know in the UK is Gosh. That's the only one we know about. Yeah.
Yeah, they definitely could be removed, and if it's very large and disfiguring or bothers him, that's not unreasonable, and there's some amazing results that some of the surgeons that specialize in this area, and again, I'd emphasize, find someone that specializes in this area to do the surgery. And again, if you contact Dr. Weiner, he could probably give you some, assuming you weren't able to travel here, he could probably give you some recommendations on somebody in the UK who would be good.
And we have some listed on our website as well at birthmark.org, and we have our 2 European directors who are good at networking as well, and you can get that from our website at birthmark.org. Kira said, it's Kira from the UK. My 3-year-old has 28 small hemangiomas from her neck down. Last week, doctors found vascular growth in his colon and have concerns her seizures may be linked. Is it likely that she has more growth internally, and what is the best way to find these? Also, can these growths affect eating? So again, that sounds like
a complex situation to deal with in this format, but the best way to image any of these things is MRI, which shows the lesions well and is there's no radiation involved. Clearly, they need to be seen in a tertiary center. It sounds like they already are to evaluate all these things. But there's several different syndromes that can affect that. Some of them are associated with GI involvement. Some of them have GI bleeding. Usually eating would not be particularly affected by this.
Like a failure to thrive wouldn't be?
Not usually, no.
Amy wants to know, she said her son is 24 with Sturge-Weber and KT. His face is covered with port wine. It's getting thicker. His eyebrows are disappearing. A pyogenic granuloma has appeared on his face. Is this common since he used to get them on his head when he was younger?
Again, not to dodge, but I'm not a head and neck person, so I would defer to the other people in the VBF that can address that. I don't even want to advise you.
Yeah, Dr. Weiner, Dr. O, Dr. Darrow, we have a lot. Alder Hay in Liverpool is where Rachel's going, and I've heard good things about them in Alder Hay.
Yes.
We know there's a doctor there that's very proactive. I forgot what her name is. Okay, so we're kind of caught up. If we haven't responded to your question because it went by too fast, because I see there's 37 of you on, please post it again. Remember, today's session ends early, so it's 5:20, and we end at 5:45 today. So we've already had 48 comments, which is pretty significant. So again, Dr. Rosen will be at our conference in Irvine, California on Saturday, October 12th. We still have some free hotel rooms left for those of you who want to come and see Dr. Wayne or Dr. O, Dr. Rosen, Dr. Nelson, our doctors from Europe, Dr. Coletti and Dr. Tom Brees will be there. This year, Dr. Tom Brees is going to be our physician of the year. Okay, so some additional comments are coming in. Batul wants to know, can you suggest any medicine for some relief for stiffness and numbness of my foot? It's hard during the rainy season.
symptoms are kind of non-specific. Sometimes for neurogenic symptoms related to any of these vascular problems, there are drugs like Neurontin, which nobody really knows how it works, and sometimes effective, sometimes not. But you could probably get it through one of the physicians over there. That's probably the only really effective drug for neuropathy.
I'm just trying to make sure that I'm not missing any comments here. So it looks like Bot Tools might be the last one. Let me just check on here, because sometimes they get hidden behind other ones. You can see so many of them are on here. Okay, that's a question on sirolimus. We did that one. Head and neck. Renee Worser DeLong said, thank you. That was exactly what she needed to hear, the advice that you gave her. Can you suggest a place in okay, so someone wants the place in the UK. We know of Alderhay and also Great Ormond Street.
Ormond Street is probably the top place right now.
Right now, yeah, it is. So Chrissy is saying she's in the UK. She has a VM on her left arm and hand. She had sclerotherapy years ago, which improved the pain, and she wears a full arm and hand compression. In November, I had a DVT and am now on long-term anticoagulant medicine. After the MRI this year, there is no option of further sclerotherapy, but I remain in chronic pain, currently improved by amitriptyline. Okay, can you recommend anything further?
I would, my first question would be, on what basis has it been decided that nothing further can be done in terms of direct treatment rather than just pain management? So again, if you can forward those images, I'd be happy to take a look and give you another opinion about that.
Yeah, so Chrissy, that would be right directly to Dr. Rosen, and they'll post there's his email right in this string here, and you can send it right to his attention. And he can take a look on them and any reports that she has from the doctors. Hello, Eric. Tiffany says, our geneticist says our daughter has capillary malformation. Is that the same as Port Weinstein?
Technically it is. Port Weinstein is a capillary venous malformation, but as we've already seen, the terminology is really variable from place to place. But in theory, that should just involve the skin, not any of the deeper tissues, a true capillary malformation.
So Lee writes, and she says, I'm an adult with a birthmark on the lower left limb, and I have been diagnosed with varicosity, CVI, lymphatic malformation in the left leg. I have problems with both legs, though, and it is quite painful. The question, if I have the birthmark, incompetent veins, and a lymphatic malformation, do I have KTS? Also, I have terrible pain in both legs. If I have a lymphatic malformation in one leg, is it likely I have them elsewhere? Do you think I need more MRIs to get to the bottom of this? Although I'm very thin, my legs are swelling and the pain is bilateral. My birthmark continually gets cellulitis as well. I don't fully understand my full diagnosis and whether such conditions contribute to my severe leg pain.
Well, a lot of information there, a long question, but people tend to focus on the diagnosis of KT as if it is some huge pronouncement about the future. And some people are very specific about who they diagnose with KT. They have to have the exact criteria. Other people, including me, think that if you have especially a limb malformation that has Port Weinstein's, abnormal veins, and if there's bony changes, and especially if there's asymmetry, most often it's just one limb involved. Occasionally we see two limbs. I think it comes under the range of KT, and the treatments don't really vary either way. So yeah, I think it's probably KT. And what was the other? The cellulitis just kind of confirms that there is a significant lymphatic component, because venous malformations very rarely get cellulitis. It usually implies that there's a significant lymphatic component. And again, managed usually with antibiotics, and if they're really intractable, there's some of the newer drugs, systemic drugs that are used if it can't be managed in any other way.
So Chris Perkins wants to know if you have any information on the PIK3CA test, PIK3A genetic testing. Her daughter's having it, they told her there's about a 20% chance.
Yeah, I think it's at this point it's mostly an interesting academic piece of information to get. It doesn't really change any individual patient's management, and it usually won't, unless there's a strong family history, usually won't be a consideration in terms of future generations or her offspring. So yeah, it's interesting information. I'm not sure it's going to change anything dramatically in terms of actual management.
So Tiara lives very close to me, an hour north of Albany from where I live, because I'm in that area. And she wants to know, because her child has the congenital hemangioma on the back, like, should they go see you, or should they see, like...
How old is the child?
Well, this was one she talked about before, the one with the one on the back.
I'd be happy.
It was the one that was niche or reach.
Yeah, I would be happy to, if you want to send me images, both any imaging that was done as well as actual clinical photographs, I'd be happy to take a look. And if I'm not the right person, I could certainly steer you in the right direction.
Oh, Chrissy answered that the main issue there, saying that it's not treatable, is the main vein in her arm is so large the sclerosis is unlikely to make a difference. That's what she said they're telling her.
Again, it depends on whether there's one abnormal vein plus normal other deep veins, or whether that's the only vein draining the arm. If it's the only vein draining the arm, it may not be anything addressable, but you'd really need to do careful venography, contrast study of the veins to see what the roots of venous drainage are. Often it's hard to demonstrate the normal deep veins when you have a very large anomalous one, but you usually can determine that.
So Patricia wants to know if there's anything new to treat skin ulcers. Her son has Parkes-Weber, and it gets ulcers on his affected foot. They use Dynaflex wraps with Dermagran B ointment.
Yeah, I think obviously the topical treatments are moderately effective, and it's as you've already discovered, Parkes-Weber is not an easy situation to manage. One thing we have found, and I'm not sure what's been done in his past workup or treatment, is that often the ulcerations are due to venous hypertension from these multiple small vessel shunts, and actually embolization can be effective, even though some people say it's not. I've certainly seen it be effective in cutting down some of the shunting and reducing the venous hypertension, which leads to the ulcerations. So depending on what's been done, that might be something to consider.
Yeah, worth exploring, it sounds like. Kelly says she has a high flow pelvic AVM. The nidus is almost completely occult. Would a partial or full hysterectomy help with the pain and pressure from the AVM?
Well, most pelvic AVMs these days we could treat very well with embolization. So I'm not sure if you've had any angiography or magnetic resonance angiography, but most of them would be suitable for embolization without surgery. And it obviously depends on how many blood vessels are supplying it and whether it involves any of the organs in the pelvis, such as the uterus, or whether it's just in the soft tissues of the pelvis. So again, if you could send me some specifics or imaging, I could give you a little bit more advice, but it should be treatable.
Ariana also wanted to know, since she's going to school in Ohio, if there's anyone there in that area, West Coast, that would treat a VM of the foot that you know of.
That's a tough one. I'm not sure why there's very few people in California that seem to be very active in this area. As a matter of fact, I have a California license, and they keep trying to convince me to come out there.
We've been trying for about 3 years to get them out there. Yeah. True.
I can get back to you at some point and see if I could track somebody down who might have more current information, but I can't give you a name as of now.
Okay. Sarah said her newly 4-year-old just was diagnosed with 8 VMs throughout her right leg. The only visible one is in the bottom of her foot. Nemours, maybe that's a hospital in Orlando, is recommending sclerotherapy. Is this the right choice when she has had few flare-ups? Are there any cons?
The age was what?
4.
There's been a long-standing controversy about when you should start treatment, whether the final result when they grow up will be better if you start early. As I said, it's still controversial. I think probably early treatment is indicated. 4 years old probably is about the youngest I'd start thinking about it. And again, if MRIs have been done, that would be helpful. I'd be happy to take a look. If they haven't been done, at some point they should be, just to get an idea of what's going on underneath. Since you give a specific number of malformations, I assume there has been some imaging done.
Yeah, and Tiara said she has level 2 ultrasounds and MRIs, and we'll be in touch and get that information to you.
Sure.
And Sarah says she forgot to mention that she believes her main reason for wanting to treat is due to it affecting her gait. She tends to walk on the other edge of her foot.
Yeah, and it's interestingly, the plantar aspect or the bottom of the foot is one of the commoner places for venous malformations. I don't know why, but clearly it makes it a little more difficult in terms of walking, and with treatment, the recoveries take a little bit longer because of the weight-bearing issue, but I would probably focus on that. The bottom of the foot is a place we would want to start early treatment, and the knee is the second area where we like to catch them early, just because it can eventually affect the knee joint itself.
So Audrey says her 2-year-old son has a facial venous malformation involving the cheek, the tongue, and the mouth. After his 7th treatment, he developed PRES, posterior reversible encephalopathy syndrome, but does not have any of the usual precursors. His doctors are currently trying to figure out why it occurred, but also leery to treat again because they're worried it'll recur. They believe he had something similar after his 5th treatment. Is this something you've come across before with patients with malformations?
Sorry, again, that's quite a bit outside my area of
because
expertise.
it's head and neck. Yeah.
Head and neck and some really sophisticated questions. So again, I would direct that to probably Dr. Bly, I would think would be the best one.
Dr. Francine Bly.
Mm-hmm.
And then Tara said, are there any new breakthrough medications and or procedures for vascular malformations?
Well, breakthrough, I would say, the biggest breakthroughs are we're now understanding quite a bit more about the genetic and molecular basis of some of these things. So I think there are some drugs in the pipeline now that look like they have promise. Right now, I don't think there's anything miraculous for actual vascular malformations in terms of systemic treatment, but I think it's on the way. And in terms of actual procedural differences, there are several new embolic agents, especially new liquid embolic agents, that are better than the ones we currently have available, that some of which should be on the market within the next year or two. And I think that will actually help our procedural results.
It's great. Sharon Israel is on. She'd say hello,
Sharon.
Another patient. So Jody Lee would like to know, would an undiagnosed VM ever be the cause for having a stubborn port wine stain and therefore be less likely to respond?
Well, it's easy enough to see if you get an MRI whether there's an underlying vascular malformation, and often there is with a port wine stain, not always. A port wine stain itself is just a cutaneous thing, and sometimes they respond well and sometimes not to laser. As we've said before, the further you get from the head and neck, the less responsive they tend to be. If we have a deep malformation with an overlying skin malformation, we generally direct the initial treatment at the underlying malformation, especially if there's pain or some other kind of swelling involved. But that should be clear from an MRI.
Yeah, her daughter has a beard distribution port wine stain that's like recurs following treatment. So I think she's probably wondering if maybe there's something underlying.
Presume she's had MRIs already, correct?
I don't think so, because Megan is like 3, maybe 3 or 4.
Getting to the point that an MRI should be done.
4 years old. Yeah. Amy said, one more question. My son is 24 with the Sturge-Weber KT, is complaining about his arm or hand being numb. Is there something we can start doing so it doesn't get worse? Like, should I get him seen? We live in San Francisco.
He should be seen. He probably should have an MRI and see what the actual anatomy is underneath an MRI and an MRA. If you can't find anybody to look at the scans or give you some advice out there, you can certainly have them sent to me and I'll take a look and give you my opinion.
Megan Campbell, we do have our expert in the Houston area, Dr. Paul Friedman. If you message me tonight, VBF president@gmail.com, I'll give you his direct email. Carrie, how common is it to have more than one kid with a vascular birthmark and both of them on the torso? Is there going to be any studies going into genetics?
Yeah, if you have two children and they both have a similar birthmark, it certainly implies that there's some link that we may or may not understand at this point. And if they're just skin lesions, I'm not sure how far it's worth chasing. There certainly are genetic testing studies that can be done. And usually families that have a familial form of these vascular malformations will come in and already tell us they have 20 relatives that have it. So it's not such a mystery. If this is the first generation that had something, it might be worth getting them evaluated. But it probably won't change anything in the near future.
Good point. Kaliko wants to know, are contrast agents needed for MRIs for vascular birthmarks?
You get a much better study with a contrast study, and it's usually gadolinium or some form of that chemical is the contrast agent that's used. You do get a much better study.
So Roxanne says, I have KTS and had a necrotic hip and went through several surgeries. Long story. Now leg has a buildup, lymphatic fluid and bulk. Any suggestions in reducing this? Hi everybody, it's Dr. Linda again with Dr. Rosen. We just went down. The internet just kind of kicked us off, so we're back on. We have 8 more minutes. So for any of you who can see us and didn't finish answering your questions, we have 8 more minutes and we'll be happy to answer them. Sorry, April. Yeah, this happened one other time in this building where it went down right where we were going through it. So might have to get one of those wands or sticks that you bring your own internet with you. So we're back on. We're here for 7 more minutes. This is Dr. Linda from the VBF with Dr. Rosen. So yeah, go ahead. I see some people are jumping on. Again, sorry that it went down. This happened one other time last year that it went down. And no guarantees it won't go down again, but if it does, I'll say it ahead of time, thank you for this session, just in case it goes down, because we're now at 5:38 and we have to go very soon. So there's 10 of you on. I'm not seeing your questions. I see 2 comments. Okay, here you are. Sorry, everybody, it went down. Okay. So I see Mihaela just joined. Sharon's back on. Kristen's back on. Jody Lee. Yeah, we have, we're ending at 5:45 today. So Tara, what are your most successful agents you use for sclerosing and embolization?
Well, as you personally know, there's several agents that have been used over the years. The ones we still probably use the most often is called STS, or sodium tetradecyl sulfate, which is usually injected in a kind of a foam formulation, similar to what they use for varicose veins. Not too tissue toxic and fairly effective. Some people use absolute alcohol, which is a very effective sclerosant, but has a much lower safety profile in terms of complications. And Bleomycin is a drug that is a very good sclerosant. We sometimes use it when a patient hasn't responded to the STS foam, and it's a drug that's been around for a while. And the only catch with Bleomycin is that when it was used as a cancer drug, there was some incidence of pulmonary toxicity, lung toxicity. The doses that we use in sclerotherapy, it's really, the risk is pretty minimal. So it is a reasonable second-line option. Yeah, so this session's not even showing up on my phone, so I guess we'll just have to keep going on from here. So it says there's 6. Thank you. What are the future ones you speak of? Actually, the future agents are not so much sclerosants as they are liquid embolics, which are used for the high flow lesions. So I think there probably are some more sclerotherapy agents on the way, but nothing on the U.S. market that I'm aware of that's dramatically different. There's probably half a dozen variations of the same kind of chemical compound.
So Sharon Israel said, in case we didn't see her comment, which we didn't see, she says, thank you. Olivia is doing great, which is great. No challenges during school DC trip and all good at sleepaway camp. So that's
is one of our heroes. So
yeah.
Glad to hear she's having a good summer.
Yep. And Dottie had submitted a question. What do you think of sirolimus for venous vascular malformations and cloves?
Well, I think for purely venous malformations, again, at every meeting we see a few cases presented with dramatic responses, but most of the good responses I've seen have been in lymphatic patients. So I think given the issues of dealing with a potent drug like that has to be given for a very long time in a young patient, I would pretty much keep it in reserve for serious problems that don't have any good solutions. And again, lymphatic's much better than venous.
So we have 3 minutes left. Sarah said, what are the risks with sclerotherapy? Is there a finite amount of times it can be done? Why do people have it done multiple times? Is it just for relief, or is it an actual treatment?
It is an actual treatment. The risks are fairly low, depending on how intact and good quality the overlying skin is on the malformation. You may or may not have areas of blister or ulceration. It's pretty uncommon, but it can happen. And there are some rare risks if some of the sclerosing or the drug goes into draining veins. There's a potential risk of deep vein thrombosis, actually quite rare. And it is a real treatment. It's just not for symptom relief, but most of these malformations have so many different compartments that you could shrink most of it and other parts will continue to enlarge, especially in a young patient who's growing. So some patients will need 15 or 20 procedures. The average patient probably needs 3 or 4, and the range can be anywhere between those. In a small lesion, one treatment may be plenty.
So Mercedes brought up a hemangioma question, and I know you like to defer those to the head and neck guys. But the thing is, she's saying it stopped growing around 2, and she's 3. So would you treat? I guess you would again just
depends on how big it is, and if it's starting to change at all. If there's no signs of it shrinking or fading or involution, you might see the right kind of plastic surgeon who could do something about it. It's kind of right on the cusp of when you would think about being more aggressive.
Renata says hello from Brazil, and thank you for this. And Alana Dolce said hello, Dr. Rosen. Rebecca Helms LeBlue says, is bleomycin safe to use more than once for sclerotherapy?
It is. Bleomycin again has a kind of a lifetime safe dose that people will not go over a certain number of milligrams per kilogram of body weight. And once you get over that lifetime cumulative dose, then the risks of systemic problems like in the lungs goes up. But yeah, it can certainly be used multiple times and stay well within that safety limit.
So is that lifetime dose based on their weight? Or?
Some people say there's an absolute number of milligrams you could get in a lifetime. And
just curious.
That's kind of what it boils down to.
All right, and somebody else asked the same question. Mercedes was also following up with her daughter that she has 15 little hemangiomas and 2 other larger ones, so she maybe should be worked up and talk to one of the experts. So thank you. You're welcome. And that brings us to 5:45. So thank you very much for this session.
Thank you.
And we'll see you at our conference in October. And those of you wanting a free clinic session with Dr. Rosen, please sign up at birthmark.org/conferences. And you can follow up with him, and he will review your files from this session. So thank you all, and enjoy the rest of your month. Take care.